I'd like to welcome everybody to our grand rounds. It's hard to believe that it's May. A lot of things happening with the upcoming AUA, the end of the year on in January 3rd. We're very lucky to have Dr. Christy Butler here, and she's going to speak to us about gender-affirming care, where we have been, where we are, and where we are going. So we're so happy to have you here, Christy, and we look forward to your talk. Welcome, everybody.
Thanks, Dr. Stoller. Thanks, everyone. I'm just going to go ahead and share screen. Okay. All right, is everyone seeing this okay?
Yeah, looks good.
Okay, well, I just want to thank everyone for the opportunity to speak with you all this morning. I'm excited to be speaking to you about a topic that's quite near and dear to my heart, gender affirming care. Given the audience, I'm going to take a surgical focus and talk about where we've been, where we are, and where we are going. I don't have any financial disclosures. In order to set the tone for today's talk, I want to start with a quote, and I want you to all to keep this in mind going forward. This is from a friend of mine who says, LGBTQ plus people make up more than 5% of the population. No matter what you do in healthcare, you will have LGBTQ plus patients. It's our job to treat them with dignity. Gender affirming care is not niche, it's not political, it's medicine. So on today's agenda, I want to review some of the history of some of the prominent trans figures and moments in time so we can better understand how we've arrived to where we are today. I'll give a brief overview of what gender affirming care approach is, and then I'll introduce some of the surgeries involved in gender affirming surgical treatment. I'm going to then focus in on vaginoplasty and some of its advancements. And finally, I'll go over some of what's in store for the future and hopefully leave some time for questions. Although trans people have been more visible in recent years, this does not make it new. Trans and gender diverse individuals have been in existence since the beginning of history. Some of the earliest documented figures date back to 1500 BC. For example, Pharaoh Hatshepsut from the ancient Egyptians was one of the first documented trans figures. They were one of the few queens who rose to power as pharaoh, but insisted on dressing masculine and being depicted as so. In the ancient Romans, we had Empress Elagabalus, was a Roman emperor who chose to present themselves in a more feminine manner, wearing dresses and makeup. In the 18th century, Chevalier d'Eon was a French diplomat and spy to King Louis XV. She convinced society that she was born female but raised as a boy, and this was the only way that she would be allowed to legally be able to present as her true self as a trans woman. In 19th century, British surgeon was the first to complete, James Berry was the first to complete a successful C-section in which the mother and child both lived. He also happened to be a trans man. And then perhaps a little closer to home, we have Dr. Alan Hart. In the earliest 20th century, he was one of the first to pioneer the use of X-ray photography to diagnose tuberculosis and save countless lives. He also happened to be a trans man. Interesting fact, he actually did his internship here at what is now known as San Francisco General Hospital before being outed and forced to leave. Despite their existence, it took some time to gain formal acknowledgement and acceptance. It wasn't until 1897 when Magnus Hirschfeld, a German physician and sexologist, co-founded the Scientific Humanitarian Committee, which was one of the earliest LGBT rights organizations. The US was a little further behind, following with their own organization, the Society for Human Rights in 1925. In tune with the theme of the civil rights era, the 1950s and 60s, things were really starting to come to a head in terms of violence and discrimination. Dr. Harry Benjamin published his book in the now outdated term transsexual phenomenon, but that was the first empathic view on transgender and gender diverse individuals, making rehearsed recommendations and advocating for gender affirming care. Prior to this, transgender and gender diverse individuals were viewed as psychologically pathological. Despite this, violence was still at an all-time high. Case in point, the Compton cafeteria riots, which took place here in the Tenderloin in San Francisco, was in response to the police violence against the LGBT community, in particular drag queens and trans women. This marked the evolution of the movement for LGBTQ rights in San Francisco. Oops, sorry. Let me go back. Skipped ahead. This was only preceded by the more infamous Stonewall riots, which took place here, took place in New York at the Stonewall Inn. It housed an underground speakeasy for LGBTQ community. It was invaded by the police, where patrons were harassed, stripped naked to check their sex, and arrested. The community rose up in a riot, and this marked the birth of the LGBT movement in America. Few years later, we had ball culture, which influenced the popular TV show Pose. This ignited in New York as a way of providing a safe space for LGBTQ community to be themselves, as well as provide a sense of community for those feeling ostracized in society. In a way, it was like reclaiming some semblance of power. But believe it or not, it wasn't until the 2000s that trans individuals actually started claiming roles of higher power in society by getting elected to political offices, such as mayor, board of education at the states, and finally gaining equal employment protection rights for federal employees. Although this slide promotes some progress and inspires some hope, I would be remiss not to mention some of the injustices that have been done to the transgender and gender diverse community and continues to do so. People have been discriminated against, targeted, denied basic rights, including healthcare. People like Stella and Fanny have been criminalized and arrested for being trans. And worse, people have lost their lives. People like Brandon Tina, who was a transgender youth, was violently murdered in Nebraska. Barry Winchell was a US soldier who was murdered for being in a relationship with a trans woman. Angie Zapata, Bianca Banks, murdered in their home state. Trans women, in particular, trans women of color, continue to be disproportionately targeted for violence. Despite the little progress that's been made, there is still much that needs to be done. So what can you do as a physician? What can we do as providers? Well, as I mentioned in the opening quote, you will inevitably have a trans or gender diverse patient, as everyone needs healthcare at some point. Given the discrimination they faced, many transgender diverse individuals are largely distrusting of the medical community. We can help combat that by offering a gender affirming approach. Now, this can be a lecture in of its own, but I wanted to at least introduce this slide with a few key principles on what you can do on your day-to-day. I'll just go in clockwise fashion. Some examples include having gender diverse imagery or neutral imagery in the clinics or in your offices, having inclusive intake forms, pre-educating your healthcare team and staff so that they're using the correct language and being sensitive to the various unique individuals that may walk through the door, symbols of allyship on your white coat or in the office, using correct pronouns and chosen names, using inclusive anatomic terminology, or even asking if it's okay to use anatomic terms, as this can be triggering for some. Avoiding invasive questions if it's not relevant to your practice. Navigating and addressing mistakes. It's always best to apologize and move on, not dwell. Establish referral patterns and community outreach. I will say, it's important to remember that you can't assume, nor should you assume, that someone is trans or gender diverse just on how they present themselves. So I wanted to present this slide a little bit of information with what does it look like to transition, or what is it to transition? And the answer is anything. Transition and identity are not linked, okay? Transition is never required of an individual. It's not practiced by everyone, and it can occur at any time in life, young, old, and somewhere in the middle. It's quite unique to each individual. It can be multifaceted, including socially, whether people choose to practice tucking or wearing makeup or wearing a certain type of clothing or how they wear their hair. Medically, if patients choose to embark on hormone usage. And then finally, surgically. I'm going to focus in on a little piece of the surgical piece now in terms of trying to understand who might seek surgery. I'll present you with why someone might seek surgery. A common diagnosis that you may see is something called gender dysphoria, and it's the official DSM-5 diagnosis when a person's is having distress for when their gender identity doesn't match with their assigned sex at birth. So this is something that you might see commonly as an ICD-10 code diagnosis. It's important to remember that not everyone who identifies as trans or gender diverse has gender dysphoria, and not everyone with gender dysphoria seeks care. But it may be a reason as to why some people might seek care. Specifically, when we're talking about surgery with removal of hormone-producing gonads, it can be a way for patients to decrease their hormone dosage, allows for personal comfort, and increases comfort in public settings, amongst a whole other host of other reasons. It's not easy for folks to get to surgery. There are many hoops and barriers for people to try and jump through in order to get to us. Historically, in the 1970s and 90s and through the 90s in America, there was extremely strict criteria. Patients had to go through extensive interviews. They had to interview their family, their friends. They had to have no signs of mental illness. As we know, mental illness can be quite prominent in this population. People were admitted to clinics for observation and assessment to assess whether or not they were truly a suitable candidate. And they weren't allowed to just seek hormones. They actually had to go forward with surgery. Fortunately, we have evolved, and our current pre-surgical requirements I will review today, although they are changing. This is what's been written by our governing body, the World Professional Association for Transgender Health, or WPATH. They currently suggest that patients be on hormones and have been socially transitioned for at least a year. Now, as I've mentioned, not everyone transitions, and so this has been found to not be completely appropriate, and they're actually coming out with an updated guidelines in the next few weeks. But as of now, patients also are required to have 1 to 2 preoperative assessment letters, either from a mental health provider or a social worker, documenting that they're an appropriate candidate for surgery. If it's for any sort of bottom surgery, it's 2 letters. And then the rest are kind of surgeon dependent and more thinking about patient safety, as well as optimizing their ability to heal from a wound standpoint. So you may see that patients may need to be nicotine free for 6 weeks, diabetic controlled, optimal nutrition, stable housing, as well as a support system in order to get them through these really intensive surgeries, and then hair removal. I'll get into it in a little bit, but we're using hair-bearing skin in a lot of these cases as a substitute for constructing a non-hair-bearing area. So patients need to undergo permanent hair removal for laser electrolysis. In terms of the current surgical options for gender-affirming care, I like to think about them in terms of buckets. So you have your voice surgery, or voice coaching, your facial surgery, feminization, masculinization, top surgery, breast augmentation, or mastectomy. It may include some adjuncts like body contouring, liposuction, fat grafting in terms of trying to, if you're making the hips curvier or straighter, and then bottom surgery, which is my specialty, and so I'll focus on that. I'm not going to talk too much today about the masculinizing side of bottom surgery because we just won't have time for that, but I wanted to at least introduce you all to the various options. You first have, removal of your reproductive organs. So hysterectomy may or may not include removal of the ovary or vagina, depending on patient sexual practices and an interest in having biological children. When we talk about construction of a phallus, your options are metoidioplasty or phalloplasty. Metoidioplasty is lengthening the virilized clitoris, and then the phalloplasty is actually constructing a more adult-sized phallus using a flap, most notably from the arm or the leg. And either one of these can be with or without urethral lengthening. In regards to feminizing genital surgery, we're all familiar with simple orchiectomy. That's probably your easiest, simplest way. Surgery. Vulvoplasty, which is more an anatomically correct term, is your construction of your external genitalia. So your creation of your labia, your clitoris, shortening the urethra. When you add in a canal, it's then called a vaginoplasty. And that can be done in a number of different ways. Options include laparoscopic, use of peritoneum or bowel, or your standard open penile inversion approach. The first feminizing bottom gender affirming surgery actually took place in the 1930s in Germany at an institute called the Institute for Sex Research. This is actually an interesting place. It was headed by Magnus Hirschfeld, who co-founded the first LGBTQ organization. It was staffed completely by transgender individuals offering endocrine and surgical services, and had a unique library on same-sex love. The surgery at the time included penectomy, orchiectomy, and then transplant of uterus and ovary. Unfortunately, the patients did not survive due to complications of the transplant. The first two patients are depicted here, Dora Richter and Lily Elby. One of their names you may find familiar, as her life inspired the movie The Danish Girl, if you've ever seen it. Unfortunately, a lot of these archives were destroyed in the Nazi book burning, so we lost a lot of good learning and documentation from this time period. As vaginoplasty evolved over the years, it started to include the construction of a vaginal canal. In the early times, surgeons were using split thickness grafts from either the back, the buttocks, or the thigh. And then it wasn't until the mid-50s, 1956, 1957, that surgeons started taking advantage of a pedicled penile skin flap to line the canal. And this is what became the cornerstone of what is now known as the gold standard penile inversion vaginoplasty. Later in the 70s is when the scrotum started being added for use of construction of the labia. Notably, all of the surgeons that I have listed here or exclusively took place in Europe. So the majority of these procedures, if patients wanted to seek surgical care, had to go to Europe. The US was quite far behind. They just didn't have as many providers, and there was a lot of fear and criminalization for offering these surgeries, much of which we unfortunately are starting to see again today. So today's vaginoplasty, the surgical components consist of orchiectomy, partial penectomy, urethroplasty or shortening the urethra, creation of or construction of the labia with labioplasty, clitoroplasty, and then a vaginal canal. In terms of the surgical goals of a vaginoplasty, it's to create a functional canal. Ideally, it's elastic, it's of adequate caliber, it's hairless, it's self-lubricating. I say ideally because we have yet to match all of these criteria. Additionally, the goal of vaginoplasty is preserve sexual sensation, allow patients to sit to void with minimal urinary dysfunction, and of course, minimize any morbidity. I wanted to show this. It's an illustration done by this artist called her name is Hillary Wilson. And it's a nice depiction of how we perform a penile inversion vaginoplasty. So you can see here, starting in the top left corner, that you have your starting anatomy. We remove the scrotal skin uncovering the underlying penile structures. We remove the corpus cavernosum, keeping the tunica in place and preserving the neurovascular bundle. The clitoris is then made from the glands. You shorten the urethra and get rid of the bulbospongiosum muscle, bulbospongiosum. The scrotal skin that was removed gets tubularized and then re-sewn onto the penile skin tube. The vaginal canal is then dissected out between the rectum and prostate and urethra, much like an open prostatectomy described by Young. And then the penile inversion happens where you invert the skin to line the canal and everything is closed up on the outside. Just to show you what that might look like in real time. So this was published by my fellowship director, Dr. Doogie. So this is a patient pre-surgery. This is right after surgery with the vaginal packing in place. And then this is her 6 months later. So as you can imagine, quite a bit of skin is required in order to line the canal. So what happens when we don't have enough skin? Well, we often don't know how much skin we're actually going to need because we don't know what the depth will be until we get in there. The goal is to go to the peritoneal reflection, but that can be different in everybody. So if we opt for a penile inversion and we don't have enough skin, we often have to take it from an extragenital skin graft. And that picture show? Here we go. So we usually have to take it from the extragenital skin graft, usually from the hip or the groin. And so for a lot of patients, this can be dysphoric and they don't want to have additional incisions. And so we looked into ways, actually we did this study last year, into how we can better predict who might need an extragenital skin graft. So this was a prospective study that was done taking a bunch of measurements. And ultimately we found that patients who've had a prior orchiectomy or circumcised have a stretched penile length of less than 8 centimeters or stretched scrotal skin of less than 10 centimeters tend to require an extragenital skin graft in comparison to their counterparts. So it's not to necessarily discourage patients from getting a prior orchiectomy, but more just can use it for counseling purposes. Some other surgical alternatives that have been explored to replace the penile inversion include use of bowel, use of peritoneum, even use of alloderm, and xenografts. And I'll just talk a little bit about that. So the rectosigmoid vaginoplasty is not new. It's been around since the 1800s, initially used in girls born without vaginas, and was not until the 70s when this was adopted for the use of trans women seeking vaginoplasty. The most commonly, you can use ilium, but most commonly you'll see rectosigmoid being used just because of its proximity to the perineum. The advantages include that it is moist. You don't actually have to dilate to maintain its caliber, and it tends to mimic a vagina in many ways. Disadvantages include with obvious of having to harvest a piece of bowel and introducing bowel surgery. It can have an odor. It tends to bleed, especially the ilium, and there's a lot of mucus production. Other things that have been explored are the use of peritoneum, particularly NYU really took this off. There was an adaptation of the Davy dog procedure, which has been used again for patients with Meyer-Rokitansky syndrome. They've incorporated using a peritoneal flap harvested off of the bladder and the sigmoid, and then use that to incorporate that as the top of the vagina. The benefit is that it requires less scrotal skin. You still need some to bridge it to the penile skin tube, but it mitigates the need for an extragenital skin graft and is a really nice option for both primary and revision surgery for those who develop vaginal stenosis. Some newer techniques that haven't quite been written up yet in the use of trans folks, but I do know it has been used, especially by some surgeons here in the area, is the use of a peritoneal pull down. Again, this is originally used in Meyer-Rokitansky patients. And the main difference is that the peritoneal flap is just taken up higher, and they'll pull it through so that the entirety of the vagina is created from peritoneum. And then lastly has been the use of the tilapia skin. So some folks down in South America have tried using tilapia skin as a means of avoiding needing a scrotal skin graft, and so patients wouldn't have to undergo hair removal. And so it's a novel technique that they have found has been successful thus far, although their follow-up has been quite limited. They've only followed patients for about 2 months, and that patient has not engaged in any intercourse. So we don't have all the data just yet. Despite these advancements, all canals require some level of lifelong maintenance. Most notably, with the exception of the colon, is that these patients have to dilate, and they have to dilate for the rest of their lives. You can imagine that this can be a really stressful process, inserting these hard plastic dilators into a new space that they may or may not have any relationship with, or if they've had a history of sexual trauma, can be quite traumatizing for folks. So on the one hand, we're trying to explore what's the best alternative for a vaginal canal, but on the other hand is how can we make this process better, knowing that these are the materials that we have to work with. And this was a study that was done out of OHSU, the use of implementation of pelvic floor physical therapy. It was a retrospective study that incorporated using pelvic floor physical therapy for folks seeking vaginoplasty. And not only did they find that by sending folks to pelvic floor physical therapy, they were able to uncover undiagnosed pelvic floor and bowel dysfunction, but it was also useful in helping patients being able to successfully dilate. About 89% of patients were successfully dilating either without pain or without difficulty at month 3. So much so that this has now become a requirement for patients seeking vaginoplasty. So patients go both before and after surgery. And it just allows them to arm them with some tools of how to relax the pelvic floor, especially considering how violated it is during this procedure. So what do we have to look forward to going ahead? Well, this is just a few things we can think of, but definitely there's a paucity of research in this field, as well as there's definitely some room for surgical advancements. And then I really want to, say that we are in a position to be able to advocate for this marginalized community and make changes, especially given the changes in public policy. One of the things I think we're headed for in the future is challenging the binary narrative. We recently wrote a Viewpoint article that's being published in the Plastic Reconstructive Surgery Journal just on this point. It's important to remember when we talk about gender being on a spectrum, it's not this linear spectrum with male on one side and female on another. And, even some of the words of masculizing versus feminizing surgery is kind of a misnomer because I think it forces people to think in this binary way. But really, gender is more of a 3D spectrum where it can really fall anywhere in between on these X, Y, and Z axis. And it's important to remember that the treatment should reflect that. More and more frequently, we are being asked about less common surgeries, things like scrotectomy or just removal of the scrotum, unilateral orchiectomy because it helps assist folks being able to tuck, penile sparing vaginoplasty because patients still use their penis for sex, but they also feel like they need a vagina, and vaginal preservation, especially when we're talking about metoidioplasty or phalloplasty. So, this is something that, I think that we need to be open to and keep in mind and not ostracize these patients who may feel that they don't fit on this binary scale. Because otherwise, I think people might feel like they're forced to pick something that really doesn't align with their identity. I'll just talk a little bit about some future research for us to think about. One thing I think that comes in mind is depth retention. I mentioned a number of different surgical ways to go about creating a canal, but we really don't know is one way better than the other. And so I think patients are interested in knowing that, and I think it's important for counseling. So I think it's, one thing that we can look into. We just need better tracking of patients, and as long as this has been around, and we just haven't been able to accurately track patients. So I think that's something that is on the horizon for us to look into. Similarly, the use of hyperbaric oxygen in post-surgical patients. The complication rates overall after vaginoplasty is like 30%, but the majority of those are wound complications, wound separation or granulation tissue. And there has been some just anecdotal use of hyperbaric oxygen just because it helps, promote healing as well as, promote blood flow to the area. And I've been talking with some of my other UC colleagues with our UC collaboration about looking into this more formally. I can tell you I've done this now on one patient and the results are quite good. So I'm excited about this prospect and being able to apply it potentially to our post-vaginoplasty patients, because there actually is a center here in San Francisco. Skin lining. So as I mentioned with the ideal vaginal canal, none of the available options as of right now meet all of those criteria. So I think there's room to think about, the use of how we can improve the lining of the vaginal canal, whether it be through stem cells or other grafting without mitigating the use of immunosuppression. And in that vein, we'll talk a little bit about transplant. There's been some rumblings about the use of transplant in trans folks. So uterine and phallic transplants are quite rare, and they've only been done in the cis population. However, there has been some talk about trying to take advantage of this and make use of this in the trans population. There's still quite a bit to think through before embarking on this, but I know some of the folks, especially at Mount Sinai, believe that they think that we can go for it. But I think one of the things we need to consider is that patients will inevitably, there's a lot of anatomical differences, needle anatomical differences, as well as having to place patients on immunosuppressants, and in order for it to be functional, what implications that might mean as far as infection goes. And I bring up this slide, not so much to make any sort of political statements, but really just to emphasize the impact that recent public policy has had on our healthcare of our transgender and gender diverse individuals. The number of anti-LGBTQ bills have sextupled in this year alone, and we're only in month 5 since compared to 4 years ago. And this impact is potentially fatal. This is something that we can act on. This is something we can advocate for and really make a difference. And so I really just want to bring that up just to bring to your attention. A lot of these bills are based on fear mongering and ignorance. There's a lot of myths out there in regards to gender affirming care. You know, that kids are too young to know their gender, but if they're cisgender, it's okay for them to acknowledge it. That people regret surgery when it's been shown that the regret rate is extremely low. We're talking 1 to 2%. That, you know, transgender patients are mentally ill and they don't know what they're talking about when everything is proven otherwise, that they're dangerous, or that we're doing surgery on kids, which is simply not true. And so I think I use this talk in order to kind of spread some of the education so that we can go on and better educate folks so that we can hopefully avoid some of the passing of these policies, because the impact of them is devastating. Resources have been removed and taken down from LGBT sites, making it difficult for patients to access quality care and help that they need. I will say that just by removing these resources or putting these policies in place doesn't necessarily stop people from seeking what it is that they need. Patients will opt for less safe options like self-mutilation. And so we need to keep that in mind. It increases mental distress. There have been numerous studies demonstrating the improvement in mental health that gender affirming care has, the improvement on, the decrease in suicidal ideation that pubertal suppression has. And so by removing all of that, we're only going to increase the amount of mental distress in America when we're already at a shortage for mental health providers. It increases when we're talking about pubertal suppression, you know, pubertal suppression really just, you know, avoids the need for the development of secondary sexual characteristics. I'll tell you, a lot of patients who've had exposure to pubertal suppression are not interested in surgery. So by removing it, it's only going to increase the need and demand for surgery. And then who knows what impact this is going to have on insurance coverage. You know, Medicare just reversed their illegalization of covering these surgeries in 2014. So by passing all these policies, are we going to start going backwards in time? You know, it's not cheap for folks if they don't have insurance coverage. I want to end on a higher note to say, you know, it really does take a village to achieve affirming care. And that village includes, and most often starts with you. You know, it starts from an affirming provider who then spreads it to an affirming team, an affirming hospital. And then if we all work together, we can achieve an affirming society where patients can be free to get the care that they need at whatever hospital and not feel like they have to hide or travel thousands of miles just to get the care that they need. I want to share a little bit of our part of our multidisciplinary team. So I wanted to list, so here is after our first vaginoplasty, we have Team Gyne and Team Urology after our first vaginoplasty this year. And I'm really excited to keep working with some of the other folks here at UCSF. I listed some resources in case you're all interested in learning more just in terms of that language or where you can get more information. And I just want to thank you all for your attention, and I'll take any questions.
Christy, that was great. We have a few questions coming through, and people can put more questions in as they'd like on the Q&A or in the chat. Howard Walensky says, how many transgender women and men are there in the United States, and what proportion choose surgical reassignment? How common in percentage is prostate cancer in transgender women compared to cis male population?
Great question. I'd say the long and short answer is we don't actually know. The biggest study was done in 2015. It was a transgender US health survey, which showed that transgender individuals made up about 0.6% of the population, although it's probably an understatement because not everyone is comfortable saying or admitting that they're trans. And so we don't actually know. I don't actually know how many of that percentage actually seek out surgery, but it's definitely a smaller number. Again, a lot of people are more stealth and we just don't have that information. In terms of prostate cancer incidence, it's quite low. It is mostly based on case reports. We think it's somewhere around 0.01%, and that's based on a study that was done in Europe. There's really only been about 10 cases of prostate cancer reported. But again, I think that just kind of points to the lack of data that we have to be better track folks. One, patients may not actually be, they still need to remember that they have a prostate, and that if there's a family history of prostate cancer or they're high risk, we still recommend that patients be screened appropriately according to AUA guidelines, even if they've been on hormones, because there's some theory that there are estrogen positive prostate cancers, because some of these folks that were developed clinically significant high risk prostate cancer have been on hormones since they were teenagers.
Yeah, Howard, to follow up on that, Christy, Howard Walensky also says, do you refer to the population as people with prostate cancer or patients with prostate cancer? Do you recommend avoiding the common term men with prostate cancer?
Yes,
Okay.
I usually use.
Okay, Yi Lee says, thanks so much for an amazing talk. Can you talk a little about the impacts of hormone therapies? What changes for patients to expect, and how reversible are they? How do you counsel these patients with hormone therapy? And do urologists in this field primarily manage these treatments for the hormone therapy?
That's a great question. Urologists don't usually, and surgeons in general, don't usually manage hormone therapy. Hormone therapy is typically either managed from a primary care doctor or endocrinologist, and sometimes gynecology, because they'll take on a primary care role. In terms of, in general, you can think of like pubertal suppression as reversible, and then any sort of hormones as partially reversible. Sorry, I need the question in front of me. So the impact on the hormones. So in general, when we're talking about, let's say, more feminizing hormones, right? So that's going to be an androgen blocker and estrogen. Androgen blocker is the goal is really to stop any sort of like the male secondary characteristics. And then the estrogen is to try to encourage more feminine secondary characteristics like breast tissue development. It doesn't have, depending on when they started, may or may not have a change on hair pattern. Some folks, if they started later on, will still get beards, they'll still have male pattern baldness. And so the earlier that patients are started on it, the more feminine characteristics they'll have and less masculine characteristics. And in terms of counseling, I don't really. I usually leave it to people who are experts in surgery, in hormones.
Okay.
So I always kind of defer to the experts.
So maybe on a follow-up on that, Christy, how do you manage this team? You've got endocrinologists, you've got plastic surgeons, general surgeons, urologists. What are the obstacles you've had creating the team that's an effective working operation here at UCSF?
I mean, I would say I didn't create it. I'm just a member. I think we have a really strong medical director. Dr. Madeline Deutsch is our medical director. She has really organized and gotten everyone together as far as the various fields. She manages most of the primary care, is in connection with the mental health folks. And then there's a separate, surgical component where we have ENT, we have plastics, we have gyne, and we have urology. And so we all work together in terms of just being able to be in open communication. A lot of meetings, oftentimes we share patients. So it's been great in terms of just being able to meet and discuss and have, more of these multidisciplinary meetings. So it's definitely more sharing and working with others.
Dr. Larry Baskin says, Christy, outstanding. Our DSD patients may get more surgery than necessary, but they do have access. Our pediatric transgender patients have essentially no access to surgery. Should we, like some other pediatric centers, have a stronger surgical program?
Yeah, I mean, short answer, yes. I think that I mean it's kind of astounding where people will put their support behind, but I think UCSF is the place to do it. We have the willpower, we have the drive, and we have the talent to be able to have a strong surgical program, to be able to better offer and more of these surgeries and do more of these surgeries.
Matt Cooperberg is getting to the end game here. Great talk. How robust are the data on long-term quality of life and satisfaction outcomes?
Not very robust at all. So, there is something called TransArc registry, which is a registry that was started by Giovanni D. There's a multi-institutional involvement that we have been getting involved with as well in terms of trying to build a more robust data set to be able to better answer these questions. And the goal is really, one, to gain some more better objective data, but two, also to have a focus on the community piece, really, like what do patients care about? Do the things that oftentimes I think what we care about as surgeons, patients don't care about, or we might be missing what they're caring about. So I think we're really trying to make sure we're incorporating community stakeholders so that we're doing this from the ground up the correct way.
Dr. Ben Breyer is interested apparently in this new Supreme Court that we have in our country with all sorts of craziness things happening. That's a political statement from my perspective. How do you think that the Supreme Court will impact care for trans people? Is there concern in the community that services could be limited on a national perspective or scene?
I'm trying to be tactful about this. I mean, the unfortunate answer is yes. I think with the current environment and the current draft that is in existence, it's challenging not only abortion rights, but access to care for teens, STI testing, LGBTQ healthcare. All of that is in jeopardy. It's kind of incorporated in one of the same, and so. Yeah, we are at risk for losing a lot of access to healthcare for a lot of patients, and especially if they turn it back to the states. There are states in particular, at least in the teens, that will completely have loss of access, and so folks will have to either travel or commit to other resources, and those other resources aren't always the safe ones. And so I'm incredibly fearful for what this has in store.
Most of these people from afar outside of UCSF narrow geographic area, is there a need for outreach to let people know what resources are available at UCSF?
Yeah, I would say so. I think there's a community member I've been working with. They do this great clinic. It's called Trans Clinique, where they actually do a telehealth clinic, and they have licensing in those states where they can reach folks and get them access to care from a telehealth standpoint. And so there are ways to partner with them and say, hey, if you have someone who's interested in surgery, how do we get them to X, Y, and Z? The problem is the cost, right? We can't treat somebody, they have to be physically here. And oftentimes if they have Medicaid insurance, like state-based Medicaid insurance, is definitely may not be covered. But there's definitely a role, I think, to be for more outreach to know, hey, we're here, we're willing to treat you, and we'll get you the care that we need.
If you had your crystal ball, Christy, and you look 5 years down the line, where do you think the biggest challenges for you and the UCSF program is?
That's a good question. I think the biggest challenge really thus far is some of the prerequisites to get patients and folks to surgery. I think resources are limited in terms of hair removal services that will even take trans folks, let alone, cover it because it's not covered by insurance. Getting letters written. Hopefully this will get better with the change in the upcoming WPATH guidelines that I think the plan is to hopefully decrease the number of letters that are required, but there's not enough mental health providers here who can write letters for everybody. And so that's going to be the biggest challenge, is getting folks to surgery. Because I think, thus far it's been welcomed at UCSF. We've had a strong staff, nursing. A lot of the leadership folks here have all been on board, which has been great in terms of just, we all know that people will get good care here at UCSF. It's just a matter of how we get them in the door.
Great. Well, we're very excited that you're heading up the urology aspect of the gender affirming surgery here at UCSF. If there are no further questions, any last words of inspiration for all of us, Dr. Butler?
I think keep doing the work that you're doing. Be open, be sensitive, and just take care of everybody. That's
great. All right, with that, I'll give everybody 10 minutes back of their day today. And Christy, thanks so much for an inspiring talk in this new frontier in urology.
Thanks, Dr. Stoller. Thanks, everyone.
Okay. All right.